Good morning. We have with us Dr. Chandrashish Chakravarti, Senior Consultant in Critical Care from Manipal Hospital, Kolkata. We welcome you to the Natco Pharma Specialty Critical Studio, and we look forward to listening to your advice to the younger generation of doctors in the space of healthcare associated with bacterial resistance. My first question to you, Doctor, is how do you foresee the changes in critical care management?
So as far as antimicrobial resistance is concerned, we all know that India is in the top of the world map as far as resistant bugs are concerned, and it's particularly for gram-negative bugs, fungal infections, and tropical infections are something which often we forget when we think of treating infections in emergency and ICU patients. So, obviously, there will be a lot of changes which will be seen in critical care. The first is now we are moving more towards treating patients who are very immunocompromised. For example, patients who are undergoing transplants. Transplants are going up in leaps and bounds across the world, and especially in India. So, liver transplants, heart transplants, lung transplants, all these patients become very immunosuppressed after the surgery. And obviously, there lies the problem with infections in this patient, particularly if they are bacterial resistant. That can really put these disciplines into a lot of jeopardy. So, critical care has a very important role to play in particularly in preventing infections, detecting them very early, because they may not present with classical symptoms of infection in immunocompromised hosts. As I said, transplant. The second group will be bone marrow transplantations, and chemotherapy patients. As we know that the number of patients with cancer are also increasing in leaps and bounds, very unfortunately. Very soon we'll be reaching a point where 1 out of every 5 patients will be suffering from advanced cancer. And all these chemotherapeutic drugs, radiotherapy, etc., puts us and puts the patient to a huge risk of infections, and they may not show or mount inflammatory response. So we pick them up very late, so they may not have fever, their WBC counts may remain normal, their biomarkers sometimes may remain normal or unpredictable. We may not make much sense of it. For example, in a cancer patient, a CRP may be high from various reasons, etc., or a WBC count may be high from various reasons. So, keeping a very close watch at the patient, detecting them early, preventing infection becomes very, very important. And using whatever armamentarium we have very judiciously, so that overall we can bring down the prevalence of resistant bugs in the environment. So.
You really shared a very broad spectrum with the various transplants, and thank you for bringing that up. What would be your message to the young ICU doctors to enhance patient care? You spoke a lot about it even in your statement here. But what else would you like to tell them?
I think with improving technology, we have to embrace the technology. And when I say embracing the technology, I mean that we have to use various, advanced modalities of diagnostics. So diagnosing them very early, as I mentioned before, becomes of paramount importance. So using biomarkers of infection, using PCR-based techniques, uh, point of care investigations, various kind of point of care investigations, um, having an antibiogram of the hospital wherever somebody is working, so that they know that what are the prevalent bugs. And it becomes very important to choose the empirical antibiotic whenever we suspect that somebody is infected. And choosing the empirical antibiotic absolutely depends upon the local flora and the local uh, microbes which are growing in that particular hospital. So it's very important to work very closely with the microbiologists, the infection control specialists, the infectious disease specialists for the young critical care physicians, and work as a team, as a multidisciplinary team in number one, controlling infections, detecting them early, choosing empirical antibiotics very wisely, and then bringing them down or de-escalating whenever we have a particular microorganism which we isolate. And it's also, I give a lot of importance to diagnostics, because sometimes we start treatment, but we don't give that much of time, or that much, we don't go that far in finding out what is the actual infection. So for that, if we have to send multiple blood cultures, if we have to send bronchoscopic samples, we need to do it, rather than being like, yes, I know there's a pneumonia, let's start with this antibiotic and see if it responds. I mean, it might respond, but the question is that you will never know what are the common organisms which are growing, and you will never be able to give a targeted therapy for that.
Strong words of advice there. Thank you so much for bringing that up. What is the prevalence of carbapenems in your practice? What are the options in treatment?
Carbapenemase prevalence is very high. So if you look at uh, like the top 3 or 4 bugs with which poses maximum challenge, it will be probably Klebsiella, followed by E. coli, Acinetobacter, and sometimes among gram positives, Enterococcus as well. If we look at Acinetobacter and Klebsiella, they are almost always carbapenem resistant. Hardly maybe 15% or so, or 18% of Klebsiella now in my hospital will be carbapenem sensitive. The rest are all resistant. Acinetobacter is obviously resistant. It has become resistant long back, so we never almost use carbapenems for treating Acinetobacter. E. coli is also going up, maybe more than 50% has become carbapenem resistant. So the prevalence is very high, to be in one word.
Thank you so much, Dr. Chakravarti, for sharing your valuable insights, and we wish you all the best. Thank you for visiting our studio.
Thank you.